Great. So thank you so much. So today I'm going to talk about the medical management of neurodevelopmental concerns in HIVEP2 disorder. And thank you to those listening who completed the survey on developmental medicine concerns. I really appreciate it. I use this survey to focus my talk on certain key areas of concern for affected families. I don't have time to touch base on every single aspect of developmental challenges in this talk, but I'm happy to answer questions at the end and talk offline in more detail. And here's my contact information. If you would like to send me an email, feel free. Here is an outline of my talk. I'll present some background information. Next, I'll talk a little bit about language disorders. I know I don't want to replicate all that's already been discussed, but I just have 1 or 2 slides about language disorders. Talk about ADHD, anxiety and depression, restrictive repetitive behaviors, and aggression and self-injury. Finally, I'll wrap the talk up with some conclusions. Before I proceed further, some general warnings. So keep in mind that non-medication interventions can be just as effective as medication interventions, but in this talk, I'll try to focus on medications. The information I'm going to talk about here is a combination of anecdotal evidence, a combination of observations from taking care of some patients with HIVEP2, some individuals with HIVEP2 disorder, and also extrapolation from data from other neurodevelopmental disorders like autism, intellectual disability. In general, there is a huge need for evidence-based research for neurobehavioral interventions in HIVEP2 disorder, which I'll address at the end of this talk. First, some background. As all of you know, HIVEP2 disorder is a genetic disorder associated with distinct facial features associated with a spectrum of neurodevelopmental impairment, including intellectual disability, autism, hypotonia, which means low tone, delayed motor milestones, and so forth. Behavioral features can include hyperactivity, aggression, and anxiety can also occur. So why is it important to address challenging behaviors and developmental concerns? The answer, I think, is pretty easy, pretty simple. These are things that affect the quality of life for individuals with HIVEP2 and their families as well. So addressing these concerns early on, whether that's through medications, through therapies, through other interventions, that can help long-term outcomes for the future. So it's actually no surprise that in the survey that some families completed, so in the survey, four families were able to complete the survey. 3 out of 4 families, or 75% of families, reported that their child was currently taking a medication to manage developmental or behavioral challenges. Let me spend a few slides just to talk about development, because it's important for the understanding of this talk. So when I mention child development, what exactly do I mean? So child development refers to a timed, ordered series of events or milestones that take place affecting domains such as motor skills, language skills, socialization, cognition or problem solving, and behavior. Neurodevelopmental disorders, then, are disorders that affect each of these domains in certain ways. And I just want to reiterate, these are clinical descriptions. So for example, if you have significant motor impairment, you may end up with the label or the descriptive label of cerebral palsy. And for genetic disorders like HIVEP2, I like to think of it as a CP-like presentation. If you have significant language issues or significant language impairment, you may end up with the descriptive label of a language disorder. If you have significant language and socialization impairment, that may lead to the clinical description of autism. If you have significant cognitive or problem-solving impairment, that may lead to the diagnosis or the label of intellectual disability. So behavioral problems can also result in different symptoms. So hyperactivity and inattention can lead to a label of ADHD. Anxiety, depression, repetitive behaviors, aggression, self-injury are also different kinds of behavioral challenges that occur. I put a star next to the different conditions, different things I'm going to talk about, focus on in my talk over here. So just to reiterate, this is a vast oversimplification, but I wanted you to get a general idea. So language was one of the areas of concern in the survey that some families were able to fill out. Language is very, very important because it's the primary way we interface with the rest of the world. I like to think of language as having two components, an expressive language component and a receptive language component. Expressive language is our ability to communicate, to get across thoughts and ideas. Receptive language, in contrast, is our ability to understand thoughts and ideas. And on one level, receptive language is somewhat like thought or cognition. It's important to view language in the context of cognition or thinking abilities. So look on the example on the left. So let's say you have a 6-year-old who has intellectual disability, who has an IQ of 50. So what you do is you take that child's actual age, 6, and multiply it by their IQ. So 50 would be 50%. So if you take 6 years and multiply that by 50%, you get 3 years of age. So a child who has intellectual disability without a superimposed language disorder, that child's cognitive abilities should be at the 3-year-old level, and that child's language abilities should be at the 3-year-old level. There's a match between cognitive abilities and language abilities. So in contrast, if you take a child who has intellectual disability plus a superimposed language disorder, so once again, look on the example on the right. So once again, we have a 6-year-old child who has an IQ of 50. So you take 6 and multiply that by 50. So that child's cognitive abilities should be at the 3-year-old level, so 6 times 50% or 3. But if there's the presence of a language disorder on top of the existing intellectual disability, that child's language abilities should be disproportionately affected compared to that child's cognitive abilities. So language disorders reflecting an impaired ability to communicate are a common challenge for individuals with HIVEP2, as you guys have heard. I like to think of 3 pillars for treatment of language disorders: one-on-one individual speech and language therapy, play in social groups where children learn to model language socialization from each other and from other kids, and then augmentative and alternative communication, which you heard about in great detail. I just have one slide on AAC. So as you guys have heard, augmentative and alternative communication refers to the use of different kinds of devices and techniques and strategies, allowing kids to communicate even in the absence of spoken speech. But I like the point that the absence of spoken speech is not a prerequisite for AAC. So these devices can be high-tech, such as an iToby device like this one, or they can be low-tech, such as a picture board like this. And AAC can be especially helpful for kids who are nonverbal, but it's not necessarily that you have to be nonverbal to engage and to use AAC. And I know that this isn't a medication per se, but it's a great intervention, and I recommend families look into it because there's a lot of potential communication abilities, and our goal is to kind of unlock that potential. Let's switch gears a little bit and talk about attention deficit hyperactivity disorder, or ADHD, which is a common feature of neurodevelopmental disorders, and HIVEP2 disorder is certainly no exception. In fact, in the medication survey completed by families before this talk, 100% of the 4 respondents said that hyperactive, impulsive, and/or inattentive behaviors were an important target for medication therapy. In terms of, so what exactly is ADHD? So ADHD is a disorder of inattention, distractibility, hyperactivity, and impulsivity. These symptoms have to occur in 2 or more settings, so home or the school, and they have to be functionally impairing, meaning they have to cause problems in the social environment, the academic setting, and so on. There are generally 2 approaches to treatment for ADHD, and both approaches are often necessary. A non-medication approach involves behavioral therapy, whose purpose is to provide parents and caretakers with strategies to redirect the child's behavior. Sometimes families think that behavioral therapy is targeted for the child, meaning behavioral therapy will kind of reroute the child's behavior, but actually behavioral therapy is more helpful for the parents, actually, and the caretakers, because it arms them with strategies to redirect behavior. If behavior therapy is not effective, then medications may be necessary. There are 3 main classes of medications for ADHD. There's methylphenidate products, which are stimulants. There are dextroamphetamine products, which are also stimulants. And then there are non-stimulant products. Treatment for ADHD often requires a trial and error approach. So usually I start with one class of medication, such as something from the methylphenidate family or amphetamine family. If that's not working, or if that has significant side effects, then I try something from the other class of medications. And if that's not working, then I try something from one of the 3 classes of medications that I haven't tried yet. In terms of kind of a general approach to ADHD medications, I've included some advice here. The first thing I wanted to mention is that I would recommend a start low, go slow approach. And what I mean by that is start at a low dose of whatever medication you decide, and then slowly go up on the dose. And the reason I suggest this is that the metabolism, or how you kind of process that medication in your body, the metabolism can be different for kids with high P2 compared to typically developing children. Some of the main side effects of ADHD medications can include decreased appetite and disrupted sleep, but both of these have solutions, and you don't necessarily have to give up on a medication because of these side effects. Adderall specifically, which is an amphetamine product, so that can lead to increased aggression in some kids, as noted by one of the high P2 families who completed the survey before this presentation. And I recommend that you wait at least 1 week before deciding whether a new medication or a dose change is effective or not. Really try to avoid the temptation to stop a medication early unless there are serious side effects. Your body can kind of take some time to get used to a dose change or a different medication. So there may be some side effects during the first couple of days that go away over time. So choosing which medication depends on your preference for a couple of things. So depends on your preference for duration of the medication itself, or how your child can take a medication, what kind of form your child, what kind of pills, or whether your child can swallow pills, or whether your child has to have a liquid instead of pills, whether your child can tolerate having a patch, and so on. So within each class of medications, so I've listed methylphenidate products, I've listed amphetamine products, and I've also listed non-stimulant products. So within each class of medications, there are short-acting forms, which generally speaking last around 3 to 6 hours, give or take, and there are long-acting forms, which can last about 7 to 12 hours, also give and take. So they're short-acting and long-acting forms in the methylphenidate family. They're short-acting and long-acting forms in the amphetamine family. And they're also short-acting and long-acting forms in the non-stimulant family. So there are some pill options. So these are medications that you can't crush or chew. You actually have to swallow them whole. There are capsule options, which means that you can break open the capsule and sprinkle the contents onto applesauce or yogurt or some other food, and you can eat the medication through that food product. There are some pills that are actually chewable. So methylene chewable is an example of this. There are some medications that come in a liquid solution, which means that if you can drink the medication, you can take, if you can drink liquids, you can take that medication. And then finally, there are some medications that come as a patch, which you can apply onto the skin and have to change every week or so, depending on the patch. Among the survey respondents, one of the HIVEP2 families reported success with Vyvanse for ADHD, but that's only one respondent. Anxiety and depression could be another problem faced by a child with HIVEP2. Now, interestingly, in the survey that families completed prior to this talk, actually none of the families suggested that this was a problem. And my suspicion, though, is that it might be an under-recognized phenomenon, given that mood disorders are common among neurodevelopmental disorders. Anxiety and depression can have a variety of manifestations. So symptoms can include irritability, excessive worry, perseveration, which means kind of focus on something and not letting go of that thought, social avoidance. Sometimes anxiety and depression can be difficult to recognize, especially with increasing levels of intellectual disability associated with HIVEP2. As with ADHD, there are two approaches to treatment. There's a non-medication approach, and that usually involves seeing if there are triggers for anxiety or depression. There's also a specific type of behavioral therapy called cognitive behavioral therapy that can be useful for anxiety, but this may be less applicable to HIVEP2 because of the presence of intellectual disability. So often medications can be necessary or may be necessary. And I've listed three broad categories of medications used in the treatment of anxiety and depression. There are selective serotonin reuptake inhibitors, which include things like fluoxetine or Prozac, sertraline or Zoloft. There are other antidepressants, and these include things like serotonin and norepinephrine reuptake inhibitors, SNRIs, norepinephrine reuptake inhibitors, NRIs, and norepinephrine dopamine reuptake inhibitors, or NDRIs. You don't have to know exactly what those stand for. And there are also benzodiazepines, which include things like alprazolam or lorazepam, which you might also know as Xanax or Ativan. In terms of kind of broad principles for medications for the treatment of anxiety and depression in HIVEP2, once again, so what I would say is I would suggest kind of a start low and go slow approach. SSRIs, or selective serotonin reuptake inhibitors, are often first-line treatment for anxiety and depression. And a low dose of this medication can possibly help mood and anxiety states in HIVEP2. One caveat to this, one warning to this, SSRIs in some individuals can lead to worsening agitation, worsening and kind of activation of behavioral issues. So just keep that in mind. I would discourage the use of benzodiazepines for anxiety just because there's risk for dependency on those medications, and there can sometimes be paradoxical agitation, meaning you expect the medication to calm or to cause child to calm down, but it leads to the opposite reaction. I wanted to spend some time, just a slide or two, talking about a specific SSRI medication called fluoxetine, also known as Prozac. Fluoxetine increases neurogenesis. And neurogenesis is the process by which brain cells mature and develop. So fluoxetine increases neurogenesis in a part of the brain called the dentate gyrus, which plays a role in memory and learning. Now, interestingly, in one of the mouse models of HIVEP2, there are maturational defects in this region of the brain, in the dentate gyrus. Now, anecdotally, some families have reported on improvements in with use of fluoxetine in language and motor skills, and in fact, loss of language skills when it was withheld one summer. And I'll just read two responses from the survey. Fluoxetine increased developmental improvements in all areas, increased fine and gross motor control, increased attention, increased awareness of environment, increased communication. And another respondent indicated fluoxetine increased speech. So this medication may address not just anxiety, but possibly cognitive and motor features as well. Of course, we definitely need to, I think we need to study this in a lot more detail before we can come up with some solid conclusions. Okay, so now let's talk about repetitive behaviors, which is another area of concern for individuals with HIVEP2. In the survey, about 25% of the respondents suggested that repetitive behaviors were a worthwhile target for medical therapy. Restrictive repetitive behaviors include stereotyped motor movements, insistence on sameness, and compulsive and ritualistic behaviors. And these behaviors tend to occur in higher frequencies in individuals with autism and profound intellectual disability, both of which can occur in HIVEP2. Sometimes environmental factors can make repetitive behaviors worse. So for example, if there are increased social demands, that can lead to worsening repetitive or restricted behaviors. And sometimes having an underlying condition such as anxiety or sensory sensitivity issues, that can also make you more predisposed to having restrictive as well as repetitive behaviors. For treatment of repetitive behaviors, I would start with a low-dose SSRI, that select serotonin reuptake inhibitor class of medications. As I mentioned previously, SSRIs can lead to behavioral activation and worsening agitation in some, so just be aware of this as a potential side effect. And for really difficult cases where repetitive restrictive behaviors are leading to significant disruptive behaviors, one possibility is that you could, on top of the SSRI that's currently being used, you could add a medication that belongs to a family that is called a second generation neuroleptic. An example of that is risperidone. And this is a kind of medication and a kind of class of medication that I'm actually going to talk a little bit more in detail in the next section, which relates to aggression. So aggressive behaviors can be quite challenging for some kiddos with HIVEP2. In the medication survey, 50%, so 2 out of 4 of the respondents said that aggressive, self-injurious, and/or explosive behavior was an important target for medication therapy. Aggressive, self-injurious behaviors include things like head banging, hand biting, excessive scratching, and so on. And understandably, they can be a source of significant parental distress for families affected. So they're pretty impairing. They can be pretty impairing for the child, but they can be quite distressing for the family and all caretakers involved. So they're important to address. So these behaviors, in terms of treatment, these behaviors require a full behavioral assessment. And the reason they require a full behavior assessment is because it's important to note if there are certain triggers in the environment that may be leading to these aggressive self-injurious behaviors. And then sometimes an undiagnosed medical problem can be the cause, or can certainly make aggressive self-injurious behaviors worse. So there have been kids who have not been able to communicate or express clearly sources of pain, such as reflux, cavities, ulcers, things like that. And treating those underlying medical conditions can really diminish aggressive self-injurious behaviors in some cases. Now, in terms of medications for aggression in HIVEP2, so there's a class of medications that I alluded to before called second-generation neuroleptics. And so these might be an option. Risperidone, or Risperdal is another name for it, is a prime example. Other second-generation neuroleptics include aripiprazole, Abilify, quetiapine, also known as Seroquel, and olanzapine. In some medications, a class of medication called, or some individuals, I should say, a class of medications called a mood stabilizer may be helpful. And this class of medications includes things like Depakote or valproic acid and lithium. I should note that the data in this sense is limited in general. One major caveat to this class of medications used for aggression, self-injury. So second-generation neuroleptics are really, really strong medications. So they're big guns, so to speak. And as a result, they have a lot of potential for some serious side effects. So these include things like metabolic syndrome, weight gain, elevated cholesterol, lipids, risk for diabetes, those sort of things. So they require close monitoring and close and careful monitoring. So let me just wrap things up with some conclusions. So there's a spectrum of neurodevelopmental impairment associated with HIVEP2, so including intellectual disability, autism, language disorder, cerebral palsy, or CP-like presentation. Often in terms of treatment, my approach generally is, let me identify the cluster or clusters of symptoms that are really impairing, and by identifying the cluster of symptoms, I can tailor the medication management accordingly. And some of you may be wondering, I didn't speak separately about autism, but part of the presentation of autism is repetitive restrictive behaviors and language impairment, both of which I talked about as kind of features of autism in this talk. And importantly, there's a great need to study what medications work and what medications don't work for individuals with HIVEP2. So I think medication surveys are a great idea, because we need to take all this insight from each of these families and come up with kind of some general consensus about what works and what doesn't work. So for example, in terms of kind of future research efforts that I'm personally interested in, one of the things I'm trying to do is kind of design a detailed survey and build upon what Narissa had already done, a detailed survey for families focusing on efficacy and side effects of different medications used for different indications, different behavioral indications in HIVEP2. And I'm also interested in studying the neurobehavioral phenotype of HIVEP2. So lastly, I just wanted to make a quick plug for the fact that I'm trying to start a HIVEP2 clinic at Boston Children's Hospital. So the goals of this clinic would be to optimize long-term neurodevelopmental outcomes and help coordinate specialty care across multiple disciplines. So the clinic would address neurological concerns such as seizures or other neurological issues, developmental behavioral concerns such as concerns for autism or global delay, intellectual disability, behavioral challenges like the kinds we talked about, sleep issues, although I didn't have time to talk about sleep, but that's certainly an area of that can be quite challenging for some families. Educational concerns such as how do I navigate the IEP process, concerns about treatments like ABA therapy or other developmental services. And the clinic would partner with physicians in other departments for referrals and coordinations of care. And then there would be opportunities for research, including biobanking and so on. Finally, just to make some quick acknowledgements, so thank you to Narissa and all the other families out there. It's amazing seeing everybody kind of come together in this setting and us learning from everybody else. I'd like to thank Dr. Chung and the Simons VIP Foundation, VIP Project, and finally Dr. Mustafa Sahin, who's my mentor at Boston Children's Hospital. Thank you.
Thank you, Sid. Are there any questions from the parents?